Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on a journey to a 250. We are currently in our nephrology modules, and this video is all about drugs for UTI and treatment of stress, incontinence, and continences. So, which of the following is the most appropriate first-line antibiotic for the treatment of uncomplicated lower UTI in this patient? A 30-year-old, otherwise healthy woman presents to the clinic with dysuria, increased urinary frequency, and suprapubic pain. A urine analysis confirms the diagnosis of uncomplicated lower UTI. The patient has no known drug allergies. Which of the following is the first-line antibiotic treatment? Ciprofloxacin, amoxicillin, nitrofurantoin, uh, uh, TMP-SMX, and ceftriaxone. So, nitrofurantoin is the first-line antibiotic for the treatment of uncomplicated lower urinary tract infections. It is effective against the common uropathogens and is often used as a first-line agent due to its low resistance rate and minimal impact on the normal flora. While effective against many uropathogens, ciprofloxacin is often reserved for more complicated cases or when other first-line options are not suitable. Amoxicillin is not typically used as a first-line agent for uncomplicated lower UTIs. Trimethoprim-sulfamethoxazole is an alternative to a first-line option but may have a higher resistance rate in certain regions. Ceftriaxone is not commonly used for uncomplicated lower UTIs and is reserved for more severe or complicated cases. So let's talk about UTIs. So UTIs are much more common in women than in men. The most common UTIs is uncomplicated acute cystitis. The majority of UTIs are caused by ascension of pathogens from the urethra to the bladder, and these pathogens are from the fecal flora that have colonized the vaginal area. The common organisms, so the most common is always E. coli, and other organisms are the staph, saprophyticus, enterococcus, Klebsiella, proteus. So the risk factors are female gender, so they are at greater risk due to shorter urethral length, sexual intercourse. So often the trigger of a UTI in women, thus the term honeymoon cystitis, is due to the sexual intercourse. So use of diaphragms and spermicides also increases the risk of UTI. Pregnancy, indwelling urinary catheters, personal history of recurrent UTIs, and some host-dependent factors like diabetes, patient with spinal cord injury, and immunocompromised state. Now these all precipitate to be a risk factor of UTI. So the clinical features are dysuria, frequency, urgency, suprapubic tenderness, gross hematuria is sometimes present, and lower UTIs feature is characteristically absent. Let's talk about the diagnosis of number one, dipstick urine analysis. So this is a positive urine leukocyte esterase test, which shows the presence of leukocyte esterase reflects pyuria. The positive nitrite test for presence of bacteria, gram negative. Nitrite test is sensitive and specific for detecting Enterobacteriaceae, but it lacks sensitivity for other organisms. So negative tests should be interpreted with caution. So another one most commonly done is the urine analysis, where we take the sample as a clean catchment stream specimen, and the presence of epithelial cells indicates vulvar or urethral contamination. So if contamination is suspected, we perform a straight catheterization of the bladder. We perform a suprapubic sample collection. Criteria for UTI. So if there is bacteria, more than one organism per old immersion field, or bacteria without WBCs may reflect contamination and is not a reliable indicator of infection. So pyuria is the most valuable finding for diagnosis. Greater than or equal to 10 leukocytes per microliter is abnormal. So we are looking for this finding to diagnose the case as UTI. So we can also use urinary gram stain, where a count of more than 10 to the power 5 organisms per ml represents significant bacteriuria. Now this concept is very, very important, and you do not believe me, but this 10 to the power 5 number is typically asked in the USMLE examination. Urine culture confirms the diagnosis. Traditional criteria is more than 10 to the power 5 colony forming unit per ml of urine from a clean catch sample misses up to 1/3 of UTIs. So the blood cultures can also be done, also intravenous pyrography, cystoscopy, and other interventional procedures. So treatment for acute uncomplicated cystitis that Is non-pregnant women, several options exist. So oral TMP SMX, like Bactrim for 3 days, nitrofurantoin 5 to 7 days, do not give if early pyelonephritis is suspected. Fosfomycin do not give if early pyelonephritis is suspected. Amoxicillin is a less popular alternative due to increasing antimicrobial resistance. Fluoroquinolones, ciprofloxacin, a 3-day regimen is a reasonable alternative to the above mentioned agents. So we need to treat presumptively for pyelonephritis if the condition fails to respond to a short course of antibiotics. So first you do a urine analysis, then you go for antibiotics. If antibiotics fail, you have to go for urine culture then. Phenazopyridine is a urinary analgesic and it can be given for 1 to 3 days for dysuria. So pregnant women with UTI, so we treat with ampicillin, amoxicillin, or oral cephalosporin for 7 to 10 days. We need to avoid fluoroquinolones because it is teratogenic. UTIs in men. So treat as with uncomplicated cystitis in women, but for 7 days. In case of recurrent infection, so if relapse occurs within 2 weeks of cessation of treatment, we need to continue the treatment for 2 more weeks and obtain a urine culture. Otherwise, treat as for uncomplicated cystitis. Now, if the patient has more than 2 UTIs per year, we need to give chemoprophylaxis, which is a single dose of TMP-SMX after intercourse or at first sign of symptoms. Alternative dose of alternative low dose prophylactic antibiotics may be low dose TMP-SMX for 6 months. Now, specific drugs like nitrofurantoin, no, it is primarily bacteriostatic and its activity is limited to E. coli. So the most common organism is E. coli. That's why the first antibiotic that we prescribe is nitrofurantoin. Mechanism of action: sensitive bacteria reduces the drug to an active agent that inhibits the various enzymes and it damages the bacterial DNA. The antibacterial concentration is not attained in blood or tissues, not to be used with proben acid. Azotemic patients interferes with tubular secretion of drug. Talking about nalidixic acid, it is a non-fluorinated quinolone, bactericidal. Mechanism of action is inhibit the replication of bacterial by interfering with the action of DNA guidance during bacterial growth and development, and the resistance is particularly very rapid than other sort of antibiotics. Urinary pH and antimicrobial agents. So acidic urine required for methenamine. So inadequate response in complicated cases. So measurement and correction of urinary pH may be attempted. So urease positive protease infections, drugs acting at higher pH should be administered. So favorable urinary pH for antimicrobial action. So if there is acidic, so nitrofurantoin, methenamine, cloxacillin need acidic pH to act positively. Cotrimazole, cotrimazole, cephalosporin need alkaline medium, and chloramphenicol need pH immaterial. They are just neutral. They act anywhere. So urinary infection in patients with renal impairment, so it is difficult to treat. Drugs like methenamine, tetracycline, cephalosporin are contraindicated, and you need to avoid the drugs like nitrofurantoin, nalidixic acid, and aminoglycoside. Also, the potassium salts and acidifying agents are contraindicated in case of UTI in renal impairment patient. So as we are covering UTI, I also want to cover the treatment of pyelonephritis. So for uncomplicated pyelonephritis, we use outpatient treatment if the patient can take oral antibiotics. We treat based on gram stain. So TMP-SMX or a fluoroquinolone for 10 to 14 days is effective for most gram-negative rods. Amoxicillin for gram-positive cocci. And a single dose of ceftriaxone or gentamicin is often given initially before starting oral treatment. We need to repeat urine culture 2 to 4 days after cessation of therapy. So if symptoms fail to resolve within 48 hours, adjust treatment based on urine culture. Failure to respond to appropriate antimicrobial therapy suggests a functional or structural abnormality. If the patient is very ill, elderly, pregnant, unable to tolerate the oral medication, or has significant comorbidities, or if urosepsis is suspected, hospitalize the patient and give IV fluids. We need to treat with antibiotics. So we need to start with parental antibiotics like ampicillin plus gentamicin or ciprofloxacin are common initial choices. For recurrent, we need to, so if relapse is due to the same organism despite appropriate treatment, we need to treat for 6 weeks. We have one more question here. So 45-year-old woman complains of urinary leakage during activities such as coughing, laughing, or lifting heavy objects. She reports that The symptoms have been progressively worsening over the past few months. Physical examination um, and urodynamic studies confirm the diagnosis of stress urinary incontinence, which of the following is a first-line treatment option for stress urinary incontinence in this patient? Alpha blocker, pelvic floor muscle exercises, anticholinergic medications, estrogen replacement therapy, and bladder training. So pelvic floor muscle exercises. So pelvic floor muscle exercises is commonly known as Kegel exercises are considered as a first-line treatment option for stress urinary incontinence. These exercises aim to strengthen the pelvic floor muscles, providing better support to the bladder and urethra and improving urinary incontinence. Now let's talk about stress incontinence. So it's the mechanism is whenever there's outright incontinence, for example, you have hypermobility or intrinsic sphincter deficiency, which leads to the leak with any cause that is causing increased intra-abdominal pressure like sneezing or lifting. So in this, there is positive bladder stress test, and there is leakage observed in Valsalva maneuver. So it may be associated with pregnancy, so recurrent or many prior vaginal deliveries. So the most effective treatment here is pelvic floor muscle exercises. Because of your urgency incontinence, there is detrusor or the bladder muscle hyperactivity, overactivity, which leak with urge to avoid immediately. It may be associated with UTI, and the treatment is exercises, bladder training, or if it is not improving, then we go with antimuscarinics like oxybutynin for reactive bladder or mirabegron. In case of overflow incontinence, where there is incomplete emptying, which leads to leak with overfilling, and there is increased post-void residual on catheterization or ultrasound, may be associated with polyuria or BPH. So for here, we need to go for either catheterization for acute retention of urine, or we can go to relieve obstruction by using alpha blockers. Thank you for watching. Keep studying hard.